Ang paningin ang ating koneksyon sa kapaligiran. Ito ang nagbibigay impormasyon sa atin tungkol sa ating kapaligiran na nagiging basehan ng ating mga aksyon at emosyon. Ang mata ay isa sa mga pinakasensitibong bahagi ng ating katawan, kaya dapat natin ito laging protektahan. Hindi maaaring palitan ng iyong mga mata, kaya mahalagang isaalang-alang ang proteksyon nito sa bawat gawain sa iyong trabaho. Ano ang protective eyewear? Ang protective eyewear ay proteksyon sa mga mata at kung minsan ay sa mukha, gaya ng goggles o face shield na idinisenyo upang maiwasan ang aksidente. Bakit ito mahalaga? May mga trabaho na kinakailangan ng proteksyon sa mata upang maiwasan ang iba't ibang mga aksidente na maaaring makaapekto sa ating mga paningin. Mga halimbawa nito ay ang mga maliliit na butil na maaaring tumalsik sa mata habang naglalagari, nagpupukpok o nagbabarena ng mga kahoy o metal. Bukod sa mga maliliit na bagay na pwedeng tumalsik sa mata, maaari rin itong matalsikan ng mga kemikal. Ang usok din na mula sa pagwe-welding o paghihinang o mula sa mga iba't ibang makina ay maaari ding maging sanhi upang mairita ang mga mata. Kaya naman, importante ang pagsuot ng proteksyon sa mata dahil ito ang pinakamahusay na depensa mula sa mga ocular emergencies. Ano nga ba ang mga klase ng protective eyewear at ano ang nararapat sa sitwasyon? Safety glasses. Safety glasses ay inilalaan upang protektahan ang mga mata ng nagsusuot mula sa mga peligro ng epekto tulad ng paglipad ng mga fragment, bagay, malalaking chips at mga maliliit na butil. Goggles. Goggles naman ay inilalaan upang maprotektahan ang mga mata ng nagsusuot mula sa mga peligro ng epekto tulad ng pagtalsik ng mga maliliit na bagay pati na rin mula sa pagtalsik ng iba't ibang mga kemikal. Ang mga goggles ay umaangkop sa mukha kaagad na pumapalibot sa mga mata at bumubuo ng isang pangharang na selyo sa paligid ng mga mata. Pinipigilan nito ang mga bagay na pumasok sa ilalim o paligid ng mga goggles. Welding helmet o shield. Ito ang angkop gamitin habang naghihinang o welding. Hindi lang nito pinoprotektahan ang mga mata mula sa tumatalsik na maliliit na bagay, kundi pati mula sa usok at nakasisilaw na kislap mula sa welding. Face shield. Ang face shield ay parang goggles din, pero imbes na sa mata lang, ang buong mukha ay protektado sa mga lumilipad na bagay. Ngayon, ginagamit ito pang kontra sa COVID-19 bilang Personal Protective Equipment or PPE para sa mga particles tulad ng virus para hindi umabot sa mukha. Ano ang gagawin kapag ang iyong mata ay nairita o natalsikan ng chemical o natamaan ng mga bagay? Talsik ng chemical. Kung ang iyong mga mata ay natalsikan ng chemical, dapat nang dumiretso na kayo sa emergency room. Importante ding alalahanin kung anong chemical yung natalsik sa mata. Kumuha ng malinis na tubig at hugasan ng mga mata ng tuloy-tuloy habang makarating sa pinakamalapit na emergency room. Natamaan ng mga gamit sa trabaho. Kung ang iyong mata ay natamaan o napasukan ng mga maliliit na bagay, importanteng tingnan kung nasugatan ng mata o lumalabo ang paningin ng natamaang mata. Kung nasugatan ng mata o may mga bagay na nakapasok sa loob ng mata, dumiretso na agad sa emergency room. Huwag igagalaw o subukang tanggalin ang nakapasok sa mata dahil may tansya na mas malaki o mas lumala pa ang sugat. Bilang konklusyon, hindi na dapat umabot pa sa ganito. Protektahan ang ating mga mata, magsuot ng tamang proteksyon sa trabaho.
Sa panahon ngayon, iba na. Ang karaniwang araw ng bawat Juan, Pedro at Maria ay makipagkita na lang sa internet. Pero, paano kung biglaang magkasakit si Pedro? Nangangati, may mga butlig at unti-unti nang di makakita. Ano na ang gagawin? Maaaring mayroon ng tinatawag na shingles o kulebra si Pedro. Maliban sa katawan, pwede itong makaapekto sa mukha at mata. Paano nga ba nagkakaroon ng kulebra? Ito ay isang sakit na nadudulot ng isang virus. Itong virus rin ang sanhi ng chickenpox o bulutong tubig sa mga bata. Maski gumaling na ang bulutong tubig, ang virus ay nananatili sa mga ugat o nerves. Sa pag-edad at pagkakasakit, maaaring magising muli ang virus at magdulot na naman ng sakit na tinatawag na shingles o kulebra. Hindi ito tulad ng bulutong tubig na nakikita sa buong katawan. Ang pananakit at putlik-putlig ng kulebra ay nakikita lamang sa isang parte ng katawan. Kapag ang isang tao ay nagkaroon ng kulebra sa may parte ng muka, ay pwede nitong maapektuhan ang ating mata o ang tinatawag na Herpes zoster ophthalmicus. Maliban sa mga butlig sa muka, maaaring magkaroon ng lagnat, pananakit ng ulo at mata, pagluluha, pamamaga ng talukap ng mata, at pagiging sensitibo sa ilaw. Sa mga ganitong pagkakataon, maaari nang magsuspetsya ng Herpes zoster ophthalmicus. Ano ang iyong gagawin kung may herpes zoster ophthalmicus ka nga? Mainam na kumonsulta agad sa iyong doktor o sa isang espesyalista sa mata upang maagapan ang potensyal na pinsala sa cornea. Ang HZO ay ginagamot gamit ang antivirals. Ang mga ito ay pumupuksa sa mga virus na nagdudulot ng HZO. Maaari rin mabigyan ng steroid para sa mata upang malunasan ang inflammation o pamamaga. Nakakahawa ang kulebra, kaya dapat maagapan ito ng maaga. Mahalagang ma-diagnose ng maaga ang impeksyon upang mapigilan ang pagtuloy nito sa HZO. Mas maganda kung maiwasan ang impeksyon sa pamamagitan ng bakuna laban sa varicella zoster virus. Ginagamit din ang varicella immunoglobulin upang maiwasan ang mga epekto nito kung na-expose sa taong may aktibong infeksyon.
Multiple etiologies, including tear film instability, hyperosmolarity, apoptosis and inflammation, contribute to the development of dry eye disease. These etiologies are connected to each other in a cyclical manner. Meibomian gland dysfunction is associated with bacterial growth, release of toxic cytokines, eyelid inflammation and lipid deficiencies, which may contribute to tear film instability. Other factors such as allergy, contact lens wear, ocular surgery and autoimmune diseases may also lead to tear film instability or deficiency, thereby initiating and perpetuating the cycle. Understanding the pathophysiology of dry eye disease is crucial to the management of the disease.
Vision is of critical importance. If you are not conscious of it, you cannot truly appreciate it. In fact, our world is built on the ability to see. Signs canvas the landscape of our cities. Vision is the integral infrastructure of our livelihoods, not to mention various sports or countless works of art. Everything relies on our ability to see. What is more, our daily lives, our work, our children's education, our ability to prosper at every stage of life depends on vision. And yet, it remains a fact that far too many people in the world today still are unable to see. Of the world's current population, there are 2.6 billion with myopia.
1.8 billion with presbyopia, 196 million with age-related macular degeneration, 146 million with diabetic retinopathy, and 76 million with glaucoma. And of those billions of people, at least 2.2 billion are disabled by their vision impairment. Further, of those 2.2 billion who have such difficulties, over 1 billion are not being treated or have illnesses that could have been prevented. Impediments to proper vision is a major social issue people around the world want solved. From 2030 to 2040, the number of eye diseases and disorders is expected to increase with the aging of the population, in addition to continued economic development centering on Asia. It is feared that even more people will suffer from vision problems, such as ones stemming from lifestyle diseases, as well as eye stress and myopia caused by the use of digital devices. At the same time, significant changes are expected in the healthcare industry. More individually customized services, growing interest in health and wellness, advancements in AI, IoT, and automation and other technologies, creating innovative treatments such as cell therapies, gene therapies, electronic devices, etc. In these times of great change in our society, precisely because of Santen's focus on eyes, by bringing together a variety of strengths, characteristics, and technologies from around the world, Santen can contribute to society.
Good afternoon, everyone. I'm Vic Paras, and welcome to the 7th episode of Season 2 and the 19th episode overall of TMC EyeTV, a series of webinars by the TMC Eye and Vision Institute, which is a wholly produced by our doctors and staff. Today, we have an impeccable lineup of speakers and case presenters in the field of cornea and external diseases to talk about a very interesting topic, which is made more interesting because it's been around for some time and yet people don't understand much about it. With me this afternoon is the head of the LASIK and Refractive Center of the TMC, Dr. Trudy Agdepa. Good afternoon, Trudy.
Good afternoon, sir. I'm glad to be able to share the stage online with you once again. Now, this time to talk about cyclosporine, its uses, as well as its advantages in various ocular surface diseases. Now, first off, we would like to thank our sponsor, Santen, for making this episode possible.
That's right, Trudy. And our speaker is a colleague who comes all the way from the city of Padua in Italy. And because of this online avenue, he's able to join us this afternoon. He will get to know more about him and the topic he will be talking about in a few minutes.
Now, before we start, we would like to request everyone to fill out the attendance and evaluation form that we will be posting later in the comment section below. Now, we listen to Mr. Gualberto M. Las Piñas IV, Head of Sales of Santen Philippines, Inc., to formally begin this event and give us his opening remarks.
Good afternoon to all our dear ophthalmologists viewing today's program. It is with great pleasure to welcome everyone to the EyeTV webinar series, episode 19, with the title Breaking the Vicious Cycle, Cyclosporines and its Uses in Ocular Surface Disease. Today's episode is extra special because top caliber ophthalmologists will join and lead us in the discussion of the topic. Santen Philippines is honored to be the industry partner of the Medical City Eye and Vision Institute for this very important episode. We support all initiatives that provide continuing medical development that cultivates insights and share best practices that can be helpful in your clinical practice, which in turn will benefit our patients because they will get the best treatment option to have the best eye condition. Santen Philippines will take a proactive approach to be social innovators and will be your partner in the field of ophthalmology. Thank you.
Thank you, Bert, and thank you once again to our partner, Santen, for your never-failing support. Now, let's get the ball rolling by starting with the lecture of our guest speaker for this afternoon. I'm very honored to introduce our guest, who comes all the way from Italy. And I'm also quite pleasantly surprised to have found out that he is a fellow alumnus of the Scapens Eye Research Institute, from where I also trained. He is an associate professor in ophthalmology at the Neuroscience Department, the University of Padua, and has been responsible for the Ocular Allergy and Immunology outpatient service at the same institution. He's the president of the Italian Society for Uveitis and Ocular Inflammatory Disease, past chairman of the Working Group in Ocular Allergy of the European Academy of Allergy and Clinical Immunology, and is a principal investigator of many clinical trials with interests on ocular allergy, dry eye, uveitis, and ocular immunology. Let's now give the floor to Professor Andrea Leonardi as he will enlighten us on cyclosporine and its uses on the ocular surface.
Good afternoon. I would like to thank Santen for this nice invitation and the opportunity to talk with you about my experience on cyclosporine, the treatment of dry eye disease, and finally, vernal cortical conjunctivitis. Let's start with the dry eye definition and some background about dry eye disease. The last workshop on dry eye, still back in 2017, had this nice definition of dry eye disease, which say dry eye is a multifactorial disease of the ocular surface characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormality play an etiological role. So in this sentence, everything is included that regards the pathogenesis of dry eye disease. In this chart, they try to show the way to become to a diagnosis of dry eye, considering symptoms of the patient and the clinical pictures, and differential diagnosis between dry eye and other ocular surface diseases. Finally, using clinical data and some biomarker or tests, you can be able to define a dry eye disease and the three major forms, which are the aqueous deficiency, dry eye disease, and the evaporative, and of course, in the mixed one in between of both of them. In fact, in dry eye disease, either there is a reduced production of tears, so aqueous deficient dry eye, or increased evaporation, the evaporative dry eye, The consequences of the ocular surface are similar because we have, in both cases, in both scenarios, hyperosmolarity, morphological changes and biochemical changes of the cornea and epithelium, and in both cases, you have inflammation of the ocular surface. Some background of the disease, is very frequent ocular surface inflammation that affects about 35% of the people around Europe here, it says, but I would say around the world. There are known risk factors. Of course, the females are more frequent affected by dry eye compared to males, older age, estrogen levels, and many different environmental factors. It still has a significant burden of healthcare system and patient, and the reduced quality of life is a major problem for this patient. Of course, if there is a corneal involvement, there might be complication and even the erosion and perforation of the cornea. There are still diagnostic challenges for the diagnosis of disease because there is no consensus and how to perform the test and the standardization of some of them. Even the recommendation about the management of the disease is not fully recognized all over the world. It's based in most of the cases on the severity of the disease and less on the etiology. The current management, however, include environmental modification when it's possible, steer substitutes, lead hygiene, which is very important, and then anti-inflammatory drugs, especially corticosteroids and immunomodulators, and particularly cyclosporine. Of course, there is a lot of research in the area, and there are new potential drugs that might appear in the next future. But we go back to cyclosporine because this is the main topic of this presentation. And I would like just to mention the background of the history of topical cyclosporine in ophthalmology, because the first diseases that were indicated as good target for topical cyclosporine were the herpetic stomach keratitis, uveitis, and allograft rejection of the cornea, at least in animal models, but these are not anymore indication for the use of topical cyclosporine. Back in the end of the 80s and beginning of the 90s, we were one of the group that suggested the use of topical cyclosporine for the treatment of vernal keratoconjunctivitis. And in about the same period, the veterinary proposing cyclosporine for the treatment of dry eye, especially in dogs. Since then, the cyclosporine has been widely used and approved in some countries for the treatment of dry eye disease. And because we need an anti-inflammatory agent that will try to modify the course of the disease in the long term without giving the side effects. In particular, cyclosporine 0.1% cationic emulsion, so the new product, has been approved in Europe in 2015 for the treatment of severe keratitis in adult patients with dry eye disease who were not responsive to artificial tears. The advantages of cyclosporine, some disadvantages, is that cyclosporine has a low water solubility. It definitely has anti-apoptotic effect on the epithelial cells and corneal cells, has a strong anti-inflammatory effect, and this is well known in the literature, but has mostly an advantage over the corticosteroids because it does not give you the side effects typical of the long-term treatment with corticosteroids. So it does not penetrate into the eye and does not affect the intraocular pressure and the homeostasis of the lens. Cyclosporine 0.1% in cationic emulsion is an unpreserved all-in-water emulsion in single dose with a posology of 1 drop a day, preferably at nighttime. And here's the indication that has been given by the European agency. What is the new thing about this product is based on Novastrop technology, is nanoparticle in the emulsion with a positive charge on the surface and internal core, which is oily soluble, where cyclosporine is dispersed. Uh, this technology has been used as a delivery system, especially for cyclosporine for dry eye disease, and we'll see later for character conjunctivitis, but will be probably used also in the treatment of glaucoma. This formulation has high advantages over other formulations of cyclosporine, especially the 0.05% in anionic emulsion, because in the cornea and conjunctiva reach a concentration of cyclosporine which is 4 times higher after a single application compared to the half dose of the 0.05. And this is because there is an interaction, but the positive charge of the surface of the nanoparticle with the positive charge and the negative charge of the ocular surface. So the interaction between the nanoparticles and the ocular surface give more possibility to give more biodisponibility of the drug on the ocular surface. The drug has been approved because there were several trials that were able to demonstrate the efficacy of cyclosporine. In particular, there were 4 trials that were developed in the last 10 years in a different type of dry eye disease, most of them moderate to severe dry eye disease, especially the last 2 trials, which included 30% of patients with Sjogren's syndrome. The primary endpoint was a composite endpoint, and we'll see what it is. I will talk mostly on for phase 3 Sansica trial, which was the one that reached this significant results to be approved by the European agency first. And the study was conducted in 50 centers of 9 European countries. And the patients that were enrolled in the studies were adult patients with a severe dry eye disease with at least 4 plus of the corneal fluorescein staining by the Oxford scale, a shimmer between 2 and 10 millimeters, and OSDI score more than 23. The OSDI score is a score, it's define the symptoms of the patient. So the clinical study was done in this way. In the first 6 months of the study, the patient were randomized into either cyclosporine once a day at bedtime, a vehicle at a bedtime, and after the 6 months, the patient were followed for additional 6 months, but the patient that were vehicle were enter the cyclosporine. So by the end of the study, all the patients received cyclosporine either for 12 months or 6 months. But the primary endpoint was fixed at month 6, and the endpoint was a combination of the OSDI and corneal fluorescein staining in terms of improvement, at least 2 grade of CFS, and 30% improvement of the OSDI. So this is the paper that shows the entire study. You can look in the literature. I just will show you some main results of the study. So the primary composite efficacy endpoint was actually not met significantly. And this was probably because the vehicle was a good vehicle and has a positive effect on the cornea staining. However, if we divide corneal fluorescein staining and so by Oxford scale and symptom by ODI, we will see the differences. This is the improvement of the cornea score or the fluorescein during the first 6 months of the study. As you can see, there is a significant improvement of cornea staining by cyclosporine by month 3 and 6, and the difference of at month 6, so at the primary endpoint, 0.35 delta, which was significantly, statistically significant, and but also for us clinically significant. And then for the rest of the study, when all the patients enter cyclosporine, they were all treated by cyclosporine. They, in both groups, they still improved the staining of the cornea. This difference is 0.35 delta between the vehicle and cyclosporine for us is not only statistically significant, but also clinically significant, because it means that, that the patient that had been treated the vehicle had 50% more superficial punctate keratitis compared to those that were treated by cyclosporine. And that means the ocular surface was much worse in vehicle-treated patients compared to those that were treated by cyclosporine. What about symptoms? Because we said the symptoms were not statistically significantly improved by cyclosporine compared to the vehicle. Vehicle actually is a good vehicle. It's now a tear substitute by itself and improve the cornea staining by itself. But as you can see from baseline, so 4+ of keratitis at the beginning of the study, in both cases, there was an improvement of symptoms by cyclosporine and vehicle. So it doesn't mean that cyclosporine does not improve the symptoms. And then when patients were switched into cyclosporine after the 6 months, you can see that the improvement is still getting better over the 12 months study. Two main results of the study were the HLA-DR expression by epithelial cells that was measured at baseline at month 6 and month 12. As you can see, at month 6, the patient were treated by cyclosporine had a significantly statistically significant reduction of the expression of HLA-DR on epithelial conjunctival cells, which is a biomarker of inflammation for the ocular surface. And then for the rest of the other 6 months of the study, when all patients were converted and were using cyclosporine, by the end of the study, even the patient that were first in vehicle, the HLA-DR was reduced and equal to the one that were treated by cyclosporine from the beginning. And this was statistically significant. The other point that to be reminded is the improvement of hyperosmolarity. And as I said, by the definition of dry eye disease, the dry eye disease is characterized by hyperosmolarity of the tear film. At month 6, when the osmolarity was measured, you can see there was a statistically significant reduction of hyperosmolarity in cyclosporine. And then at the end of the study, when both groups were treated by cyclosporine, in both cases, hyperosmolarity, even the long term, was improved, was reduced. We put together the results of 2 studies, the 2 main studies with cyclosporine. They've been the SICA-NOVA and the SUNSICA in this pool analysis that included 629 patients treated by cyclosporine, and tried to divide the patient by different subtypes based on sex, menopause status, Sjögren, yes or no, age or duration of the disease, to look at if there was a subpopulation that was more indicator for the use of cyclosporine. But in all cases, as you can see in this meta-analysis, in all subgroups were in favor for the treatment with cyclosporine. So could not find a subpopulation that is the one that is more targeted by cyclosporine. Even look at the all patients affected by Sjögren syndrome, or the severe patient by Sjögren, if there is a population that was better treated by cyclosporine or vehicle, but all were in favor of the treatment with cyclosporine. After this study, there was an extension SUNSICA study that we call post-SUNSICA, meaning that some of the patients that were treated for 1 year were followed by 2 years to see if after stopping cyclosporine, there was a new disease coming up. So if how long it takes to have a recurrence of the disease after the patient were treated by cyclosporine, and this was the rationale for this study. And here results that are quite interesting because the rates of relapse in patients that were improved by the Sansica study was different in patients that were treated by cyclosporine for 12 years, for 12 months, compared to those that were treated by 6 months. And in fact, about less than 40% of the patient had relapse in this post-Sansica study, but the ones that were treated with cyclosporine for 12 months in the first part had relapse in 35% of cases, and the ones that were treated for 6 months had a relapse in 50%. That means if you treat long with cyclosporine, you have a better chance to have a longer duration of the effect of the drug. In fact, the time to relapse for the one that were using cyclosporine for 12 months was about 7 months, but the one that were treated by 6 months at the time of relapse was about 5 months, so 2 months later. So that means that cyclosporine has a long-term effect as long as you use it for an extensive time. Of course, there are some side effects. Some are ocular related, and the most one related is the some discharge, mostly burning, because all type of cyclosporine have a burning effect on the ocular surface. So the summary of this day was the time to relapse was longer if you treat the cyclosporine as long as you can. And the safety reports are quite good because cyclosporine was kind of relatively safe and provided a good relief of symptoms and a reduction of the cornea staining in the long term. There are few other studies on the use of cyclosporine at this concentration. In France, they had the opportunity to use cyclosporine before at this concentration, this formulation, before the marketing authorization in Europe. So they were able to treat naive patients with dry eye symptoms, or to treat a switch from a previous cyclosporine anionic emulsion, or to switch the cyclosporine from galenic preparation hospital made. So they had a huge amount of patients, and as you can see, the dry eye symptoms and signs remain stable or were improved in most of the patients as early as the first months, and this was maintained for 1 year. So in real life, the switch or new cases had a good response by the patients. And even in this study, it showed that there was a percent of patients from 5% after 1 month of treatment to about 13% of after 12 months that reached completely cornea cleaning. So it means they were Oxford stained, for instance, stained by 0. Of course, there are, even in this study, we reported some adverse event. The most frequent is the burning sensation and some irritation of the ocular surface. Recently, has been published in a study from Korea experience where they had already cyclosporine 0.5% anionic emulsion, and their patient were switched into the 0.1% emulsion in patient with Sjogren's syndrome. And as you can see by the results, and just partially some of the table reported in this paper, in patient with dry eye disease, the switched from 0.05 to 0.1% was effective in improving ocular symptoms, conjunctival staining, cornea staining, especially in patients with severe keratitis. So the switch was actually improving the effect of cyclosporine on the ocular surface in severe patients. Online, there is a experimental model in severe and not severe dry eye patients, or in the animals. And even in this model, they showed that the 0.1% was more effective than anionic emulsion 0.05% in improving tear function, cornea staining, reducing the pro-inflammatory cytokine expression, the percent of TH4, TH1, and TH17 cells, reducing apoptosis, and increasing the density of conjunctiva globus cells. So this results in the experimental model are kind of mirroring what is actually happening in our patients. I have one clinical case to show you, just an example. This is a 55-year-old female post-menopause with symptoms and signs that were actually asymmetrical in the right eye and the left eye. As you can see, the left eye is more affected. But in addition to dry eye condition, she had a history of depression. She was on beta blockers, even though the markers for dry eye disease associated with syndrome were negative. And here's the tear film data. So in a patient like this, we can ask ourselves several questions, and the answers are not one way. But in this case, even the patient was asymmetrical, and we decided to put the cyclosporine, put the patient on cyclosporine in both eyes, even the one that was less affected, because it presumably in the long term it will turn to a severe dry eye as well. Of course, several questions are on the hormonal therapy, supplementary therapy, how to change the antihypertensive treatment. And so we have to interact with other physicians to try to reach the best treatment for this patient, avoiding side effects by other drugs. And this is another case, this is the same patient actually with staining and high magnification at baseline. And after 1 month, you can see the cornea is much clearer than before. Another case, 4+ keratitis, and after a few months, you can see the cornea is much better after cyclosporine treatment. So in summary, for this part of my talk, the dry eye is a chronic inflammatory condition. The cyclosporine is an ideal drug for the treatment of inflammation of the ocular surface. Even the long term does not give important side effects, but turn the disease into remission or having a more tolerable manifestation of inflammation for these patients. I would like just to mention another indication of topical cyclosporine in vernal keratoconjunctivitis. conjunctivitis. Vernal keratoconjunctivitis is it's an inflammation that is completely different from the one of dry eye disease because it's severe type 2 ocular eosinophilic inflammation, which affects mostly children and young adults. Dry eye affects mostly adults or older people. Has a seasonal occurrence or perennial, depending on the area, and impacts very importantly the quality of life for the patient and the family. So even in this case, there are challenges in diagnosis, not much, but mostly in management of the VKC. Generally, the management of VKC has followed a step-ladder strategy, starting from non-pharmacological approach. So education of the patients, avoidance of the exposure, sometimes psychological support. And then the first pharmacological approach is the treatment with multiple drugs, antihistamine, mast cell stabilizer, for a high dose, so frequently and for long term. In addition to that, in case of recurrences of inflammation, we should use systemic antihistamine and topical corticosteroids, preferably what I do at short pulses. And when it's not enough, we add immunomodulators, and cyclosporine is the first choice. Cyclosporine has been approved by in the treatment of VKC by the results of these trials, the Vectis study, in which patients were treated by cyclosporine. They were very symptomatic and severe VKC patients were included in three arms of cyclosporine four times a day, twice a day, or via, and the endpoint was at month 4. The primary endpoint was a composite score, including CFS and the use of rescue medication or the occurrence of ulcers. So the main results of the study was that the patient treated with cyclosporine achieved a significant greater improvement of these composite scores, so they were improving sign and symptom very quickly. They used much less rescue medication compared to the vehicle group, and there was a great improvement of the quality of life, and the secondary endpoints, symptoms, and other signs were improving. This is the curve of the improvement of the quality of life in terms of symptom domain. The patients were also treated by cyclosporine for the additional 8 months of the study, and as you can see, this graph, the situation of the cornea remained stable for the additional 8 months of the treatment with cyclosporine, so they did not have recurrence. And these are the graph for the photophobia, mucus discharge. So the symptoms decreased rapidly in the first part, and then of the study then were maintained stable. There were still some side effects, mostly burning sensation, but the cyclosporine in children is very well tolerated. So the conclusion of the study is the improvement of keratitis, the symptoms and quality of life were achieved by cyclosporine during the initial 4 months of the evaluation period and the following 8-month follow-up study. And the cyclosporine were very well tolerated and accepted by the patient. So just to finish, a clinical case that I call misunderstanding and mistreatment, because this kid had the diagnosis of VKC at 8 year old. It was treated by topical dexamethasone, and the patient did not understand, the family did not understand that they had to treat it just for a limited period of time. So he used this topical dexamethasone for a year, and then he developed a cataract bilateral. It was treated by phacoemulsification in general anesthesia. And then the year after, he represented with typical signs and symptoms of VKC. This is the picture when he presented, was putting cyclosporine 4 times a day. And after a few months, these are the picture of the nice improvement. The year after, again, we started again cyclosporine 4 times a day. And at the end of the season, this is the situation, very quiet. It did not have to use rescue medication anymore. Thank you for your attention.
Thank you very much for that very informative lecture, Professor Leonardi. Indeed, the use of cyclosporine has grown in the past years and has become more widely accepted in the treatment of ocular inflammation and various ocular surface disease. However, not so much here in the Philippines for various reasons. So I'm very sure that our audience has a few questions about that you might want to answer, Professor.
For
Sure.
this part of the program, we will be entertaining these questions. Kindly type them in the comment section below for us to be able to ask them to Professor Leonardi. Dr. Caparas, you may have a question for Professor Leonardi.
This is a continuation, I think, of what I said. No? So, the benefit of cyclosporine is well understood, but in the Philippine setting, cyclosporine is expensive for many patients. Now, for the benefit of our audience and to guide our general ophthalmologist, can you give us a definitive sign or symptom, a tip that you look for, and that would trigger your prescription of cyclosporine?
Well, thank you for the question. This is a very important point because cyclosporine is expensive also in Europe and in Italy as well, especially for dry eye patients. Not for vernal because at least in Italy, for VKC, the under age of 18, cyclosporine is full reimbursed, so the patient they don't have to pay anything. For dry eye, it's still expensive. But one thing that we did not show in this slide kit, but has been shown by the study by others as well, is that when you are treating the patient with cyclosporine in the long term, the number of drops of tear substitutes are decreasing significantly in the long term. So they use less tear substitutes, which is cost effective. It's not like the tear substitutes do not cost anything. They're not reimbursable, at least in Europe, and I think in most of the countries. So by decreasing the amount of tear substitute and increasing the quality of life, I think this makes the change for the patient and for the doctors as well to indicate cyclosporine treatment, even though it's kind of cost effective. Long term, it might turn into better quality of life and less use of the tear substitutes.
Yes. But what would you look for? What sign? What presentation of patient would you definitely prescribe cyclosporine?
Well, the right patients are the ones that have a cornea staining, at least 3+ of the by the Oxford scale. It doesn't mean that it doesn't work on less severe keratitis, but the results are not so impressive in the short term. It might be more significant in the long term because cyclosporine takes a while to get into work. Anyhow, symptoms improved quite early, even though the study did not show a significant improvement compared to the vehicle, but it's not like the symptoms do not improve. Symptoms improve and the patient gets better in, I would say, several weeks or few months, not as quickly as it can happen in vertical conjunctivitis, for example, where the symptoms improve very quickly after starting cyclosporine. So the right patient is a symptomatic patient with keratitis for dry eye disease.
Thank you.
So, is there a risk for ocular infections in the setting of a chronic cyclosporine use?
So thank you. This is a very important point. I've been using personally cyclosporine for, I would say, 30, 35 years, which is not a good thing to say because it means getting
Ages.
older. But anyway, so we started with 2% concentration cyclosporine galenic preparation, which was less tolerated than the one we are using right now. Um, but even with high concentration, I never experienced any bad infections with the use of cyclosporine, even the long term. I would now with lower concentration, like 0.1%, the risk to have infection is much lower. I've never seen herpes, cornea herpes occurring in patients with cyclosporine. Uh, but if you use, especially in atopic patient, corticosteroids, the chance you get the herpetic keratitis with steroids is much higher than the chance you get keratitis in patient treated by cyclosporine. In fact, um, uh, there is an indication also for cyclosporine in herpes keratitis. I think you will hear a clinical case later on, or some discussion about the alternative use of cyclosporine that are still off-label. But the immunomodulating effect is not immunosuppressive effect at this concentration of cyclosporine, even on the surface.
Yeah. Okay. Thank you. We have another question. Have you noticed any specific differences in severity of dryness in patients with Sjogren's depending on specific antibodies, such as anti-Ro or anti-La?
Um, Thanks again for this difficult question. I never noticed because we did not look at this fact in our patients, and I don't have a good answer for this question. But I would say I did not notice any difference in between the type of antibodies and the severity of the disease, at least in our patients.
Okay.
We have another question here. Do you have any experience using cyclosporine for secondary GPC due to contact lens use? And if so, what have been your results, and how do you administer cyclosporine?
Thank you. And first of all, we don't see GPCs anymore, or very rarely in our population because of the change of contact lens and the change of materials and the use of the lenses. So the GPC became a rare, very rare condition, which disappears after few weeks of suspending the use of contact lenses. So in this case, I never use cyclosporine for GPC related to contact lenses, and I don't really see the indication because a few courses of corticosteroids might resolve quicker the condition. And in this case is you don't need a long-term treatment for GPC because it disappears once you stop the contact lenses. Of course, the problem is not the treatment, but the problem is the lens and how to use the lens in the particular patient.
Okay.
All right.
Thank you.
Dr. Caparas, do you still have a question for Professor Leonardi?
I think that's all I have. Do we have another
Uh,
one on top?
I know. I have one more question for Dr. Leonardi. I guess the problem with patients with dry eye disease, this is a problem for patients with dry eye disease, and most especially with kids with VKC and shield ulcers. Their main problem is the stinging sensation, the burning sensation. Now, would you advise instilling a drop or two of a lubricant, maybe sodium hyaluronate, to somehow mask that stinging sensation? And if you do give a lubricant before cyclosporine, would that in a way affect its absorption? what tips can you give to improve patient compliance?
Okay, I think it's a completely different situation between dry eye and VKC. Let's talk about dry eye first. It is true that there are subpopulation of dry eye patients that do not tolerate cyclosporine, and this is quite normal for such a drug. Um, in these cases, I think you can do a combination of topical steroids for short term, in addition or before the use of cyclosporine. Uh, in dry eye patient, usually, or at least the indication is once a day. You can even add another drop during the day, but this is off-label. But you can, as a doctor, you can do whatever you want if it's an indicator for the single patient. We have to distinguish the governative indication and what the condition of a single patient is in front of the doctor. So I think the second dose in dry eye patients sometimes is useful. It could be helped if you put the tear substitute before cyclosporine. You have to wait a few months, a few minutes maybe, but I don't think it doesn't make a great change. In the long term, what I observed over the years is that it gets more tolerable. I mean, even the patient with severe dry eye may have a burning sensation in the beginning, but after a few weeks, that's get much better. It gets more tolerated. The number of dropouts for this reason was actually very low, even in the study in real life. For VKC, it's completely different. Because they tolerate the 4 times a day, even 5 times a day very well. They might have a burning sensation, but it's very mild and much more tolerant than the galenic preparation. I didn't have any dropout with cyclosporine 0.1% in VKC. Of course, they have severe symptoms, especially when you have the ulcer. In case of the acute ulcer, cyclosporine doesn't work as well as corticosteroids. So you have acute ulcer. The suggestion is to use topical corticosteroids at high dose for short time, and then continue with cyclosporine in the long term.
Thanks.
All right. I think we have more questions for Professor Leonardi. Would you continue cyclosporine in patients who have remained asymptomatic for 6 months?
I don't know if this is for VKC or dry eye patient. Let's talk about dry eye patient first. I think if they get asymptomatic, you can. I think in dry eye patient, I would continue as long as I can because it's a chronic disease. There is no way back to normal condition. So you can even choose, if the patient is completely clear cornea, to do a drop every 2 days or lower or maybe once every 3 days, once a week. But I suggest not to stop because severe dry eye is a chronic condition and at some time will come back definitely. In VKC, if the patient is completely asymptomatic and there are no active signs, especially in our country, VKC has seasons. So in the winter time, we try to stop it or reduce the dose and try to leave the kid without any treatment as we can. When it comes back to a new season, of course, we can start cyclosporine as soon as we can because we know that at some point it will be very symptomatic.
Thank you. What is the youngest age that you can use cyclosporine in children?
Well, the study has been conducted in children from age of 4. So the indication that the authorities gave for cyclosporine is age 4, but of course we have been using cyclosporine even in youngest children. And cyclosporine rarely occurs under age of 3, and in those cases, it's always difficult to have a right regime of treatment because it's difficult to put eye drops in younger children. So the cyclosporine works well in the long term. So it may be difficult to have the youngest children with such a therapy. But I don't see any contraindication. The only contraindication is because it's been approved because the study has been conducted in in children under age of 4.
All right. Professor Lunardi, one more question. In case of recurrences in VKC, can we give a low dose daily maintenance dose for kids? Can we give it for a year or so? Or how long can we give it?
Well, you can give for as long as you can because there's no absorption of cyclosporine in the blood. So even the long term, the blood level of cyclosporine has been checked, and there was no clinically absorption of the drug. There were no changes in liver function or renal function ever. So there is no concern about effects. Of course, if the patient is doing well and is a permanent and perennial VKC, as far as he get improved, we try to lower the dose to twice a day or even once a day for the long term, and it can be used for many years with no problem.
Thank you for that, Professor. Dr. Capres, I think that's all the time that we have for now. We'd like to thank everyone for all your questions for Professor Lunardi. Now, we would like to extend our gratitude to him for gracing this episode and for sharing with us his expertise despite his busy schedule. Now, I'm sure that our viewers have learned a lot from him. Now, we have a lot in store for you, so stay tuned for more of this episode after this short break. Thank you, Professor Lunardi.
Thank you so much.
Dry eye can be developed in a healthy person or even a suspected dry eye patient. In fact, dry eye disease is especially common after cataract surgery. This may be due to a combination of surgical factors. Treated as a drug in dry eye treatment, Aqueous helps improve the tear film's water and mucin elements and supports its stability to help relieve symptoms. It is suitable for mild to moderate dry eye patients who are unsatisfied with artificial tears and suffer dry eye symptoms caused by short BUT dry eye. Aqueous helps improve visual function by decreasing higher-order aberrations. Some patients may also benefit from a long-term approach to address underlying inflammation. Using artificial tears in corticosteroids has its pros and cons, but Ikervis provide an alternative that's safe and reliable. Use Ikervis long-term for better results and sustained benefits.
Dry eye disease derives from problems with the quantity or quality of the tear film. The healthy tear film is composed of a specific balance of salts, lipids, proteins, and water. Together, these lubricate and protect the eye. Alterations to tear production or composition can reduce the stability and increase the osmolarity of the tear film, leaving the eye prone to damage or irritation. When irritation occurs, the ocular tissue recruits T cells into the area. These secrete cytokines, leading to inflammation and further altering tear production. Over time, this vicious circle of inflammation can lead to corneal damage, which can be assessed using corneal fluorescein staining, or CFS. Chronic conditions such as keratitis and dry eye disease require ongoing treatment. While anti-inflammatory corticosteroids have been used to manage the condition, there are concerns about the safety of long-term use. Topical cyclosporine is a well-tolerated treatment for dry eye disease that reduces inflammation at the ocular surface. However, the hydrophobic structure of cyclosporine makes it difficult to create topical ocular formulations, and the tear film creates a barrier which reduces drug penetration. Pharmacists sometimes prepare compounded solutions of cyclosporine for patients with dry eye disease. However, preparations created in pharmacy may not be standardized, nor are they clinically evaluated for their safety or efficacy. Aqueous is a standardized, licensed formulation of cyclosporine, solubilized in nanodroplets composed of oil and positively charged surfactants. Following administration, the positively charged nanodroplets in Aqueous are electrostatically attracted to the negatively charged cellular layer of the corneal surface. This attraction allows for optimal spreading and prolonged adhesion of Aqueous on the ocular surface, facilitating maximum delivery into the corneal epithelium and to the T cells beyond. Here, cyclosporine can inhibit IL-2 cytokine production, impeding T cell differentiation and proliferation and reducing further inflammation. Aqueous delivers cyclosporine to the cornea and is effective at up to 10 times lower concentrations than unlicensed preparations. Research shows that following once daily dosing with Aqueous, the expression of inflammatory markers begins to fall within 1 month of treatment. As T cells have a lifespan of 100 to 120 days, and cyclosporine inhibits new undifferentiated T cells, clinical improvements might take some time to appear. Clinical studies demonstrate that tear osmolarity can return to the normal range within 6 months, and that symptoms can continue to improve over 12 months of treatment. The formulation of Aqueous was developed over 10 years and has undergone full clinical testing. Aqueous is manufactured in a controlled, sterile environment and is provided with consistent labeling and instructions for patients. Its once-daily nanodroplet formulation is well tolerated and effective for long-term use. Break the vicious circle of inflammation in dry eye disease with Aqueous.
For the next part of our program, we have invited several consultants from the section of cornea and external diseases of the medical city to discuss various cases where they've used cyclosporine on label and off label and able to document their effects and results. So this gives us a real world first-hand account of the experiences with the drug and when it is best to use the medication. So for this part, we'll have Dr. Trudy moderate, as I will be giving one of the cases.
Thank you again, sir, for inviting all of us to share your experiences with cyclosporine. Let me introduce to you my colleagues from the section of cornea, external disease, and refractive surgery who have given their time today to make this discussion richer. We have Dr. Ivo John Dualan, Dr. Lisa Yu Mateo, Dr. Ellen C., Dr. Keisha Duyung Colenon, and of course, Dr. Victor Caparas. Now, our first presenter is Keisha, followed by Ivo. Keisha, you may start.
Okay, so good evening. It is a great pleasure once again to be part of this episode. My case will highlight the utility of topical cyclosporine in managing ocular surface disease after cataract surgery. MD is a 61-year-old housewife who was actually referred to me due to blurring of vision 5 months after cataract surgery. Back in March 2020, she underwent phacoemulsification with a multifocal IOL in both eyes, and 5 months later, she noted increasing blurring of vision with occasional redness and foreign body sensation. She is postmenopausal and is allergic to some medications. She was already diagnosed with dry eye prior to surgery, which was managed by topical lubricants by her attending ophthalmologist. Before she was referred to me, she was already on the following ocular medications, namely loteprednol, PEG 400, and a carbomer. Notably, she was on amitriptyline for migraine prophylaxis. Her OSDI was severe at 44, and more importantly, she scored at least half of the time for light sensitivity, foreign body sensation, and eye discomfort. And true enough, she also reports blurred vision half of the time. She's also very much uncomfortable in windy conditions, low humidity, and air-conditioned areas. Visual acuity on the right eye was 20/20 and only 20/25 on the left eye, despite an excellent refraction. The lipid layer on the right eye shows a grayish to whitish hue, which means there is lipid deficiency. And on the left eye, although you can appreciate a reddish to bluish hue inferiorly, which represents your lipid, there is a limited upward spreading of this lipid layer. And thus, it is more concentrated inferiorly, as you can see in the video. The average tear meniscus height was high on the right at 0.46 mm and normal at 0.24 on the left eye. However, you will also notice that the value at the central meniscus varies widely from the values on the nasal and temporal areas. This is commonly seen in patients with conjunctival folds or conjunctival chalasis, which this patient has, and the Schirmer's test with anesthesia is slightly lower on the right at 5 millimeters and 8 millimeters on the left. The non-invasive tear breakup time on the right eye is only 1.15 seconds, and this was decreased compared to the value pre-op. The tear breakup assessment shows a line break, which is consistent with mild to moderate aqueous deficiency, and this was seen in the Schirmer test result earlier, although it was just low borderline. There's also a random break, which indicates increased evaporation and is consistent with the lipid layer assessment shown earlier. And in this video, you can also appreciate some conjunctival chalasis temporally. And the patient also has conjunctival folds centrally, but this was obscured by tear pooling. The non-invasive tear breakup time on the left eye was 4.40 seconds, and this was also decreased compared to the value preoperatively. The tear breakup assessment shows a random break, which indicates increased evaporation. In this video, you can also appreciate punctate staining centrally, directly obscuring the patient's visual axis. And I think this could explain the decreased visual acuity on this eye. More clearly, you can also see the conjunctival chalasis centrally. Assessment of the central 8 glands in the upper lid revealed a grading of A2-B2 bilaterally, A being the Maybom quality, which is cloudy particulate, and B being the gland expressibility, which is 1 to 2 glands expressible. The mammography shows grade 2 Meibomian gland dropout in both eyes. My diagnosis was as follows: evaporative with mild aqueous deficiency, dry eye, Meibomian gland dysfunction, conjunctival chalasis, grade 2, and punctate epithelial keratopathy on the left. So I started the patient with a preservative-free sodium hyaluronate and continued the carbomer gel. I also discontinued loteprednol and shifted the patient to cyclosporine 0.1% 4 times a day. I started with a high dose because of the coexisting conjunctivochalasis and MGD, which are known pro-inflammatory ocular surface conditions. I also discussed the possible effect of oral amitriptyline on aqueous production, and this was tapered safely by her neurologist. In addition to these, I did IPL with MG expression or meibomian gland expression to more effectively manage the meibomian gland dysfunction. After 3 months of treatment, the patient was happy. Her vision significantly improved on the left eye, and you could say she was now 20 happy. Her symptoms also improved. From an initial OSDI of 44, it was down to 27. And I also highlighted in green the improvements in terms of specific symptoms. She now only feels pain and blurred vision some of the time, and she is more comfortable in windy, low humidity, and air conditioned areas. Finally, the ocular surface greatly improved in both eyes, as you can appreciate in the videos. The tear film is more stable after each blink, and there's also complete resolution of the corneal staining on the left eye. All these despite the presence of bilateral conjunctivochalasis. In summary, this case highlights the importance of ocular surface management in achieving optimal refractive surgical outcomes. It also shows how dry eye can impact quality of vision, especially among those with multifocal IOLs. Finally, recognizing pro-inflammatory conditions such as MGD and conjunctivochalasis is essential in dry eye management, and cyclosporine 0.1% is highly effective in managing ocular surface inflammation in this setting. Thank you very much.
Good morning. Okay, good evening. It's my turn to present. Thank you for joining us this evening. I'm going to be presenting two cases of cyclosporine for aqueous deficiency dry eye. And because it's two cases, I'll be talking fast, so try to keep up. Okay, so next slide, please. Okay, so my first case is a 55-year-old female who is a professional singer. Okay, and she came to me for persistent red eyes and contact lens intolerance. This specifically because when she performs, she would rather wear contact lenses rather than wear moderately thick glasses for her moderate myopia. Okay, with this, she was diagnosed to have rheumatoid arthritis, for which she is on methotrexate and folic acid, and the patient is menopausal as well. Okay, next slide. Okay, she has been seen by other doctors, okay, and she has been prescribed various lubricants for her eyes, and has been given nafzolin and phentermine maleate because obviously redness is a big issue for her, especially when she performs. Okay, and of course, she would like to wear continuous contact lenses despite the discomfort, and she had rare spectacle use. We all know that for higher prescriptions, it's no contest. No, contact lenses would give you better vision than glasses. Okay, next slide. So I always do OSDI for all my patients, and obviously for this patient, it's very severe. No, it's severe, 61. Okay, next slide. Her uncorrected distance visual acuity is 2200 on the right, 2050 on the left. Okay, but everything else seemed to be unremarkable. Next slide. Okay, tear breakup time was just 1 second, sometimes shorter. On her tear film oriented diagnosis, which is something I use more often nowadays, she presented with area break with a lot of corneal fluorescein staining. Okay, Schirmer's test was 2 on the right and 0 on the left. And of course, she had diffuse punctate epithelial erosions on both eyes upon slit lamp exam. Next slide. Okay, her tear breakup pattern was area break here on the right eye. Next slide. And as well on the left eye. Okay, so you can see a lot of staining. Okay, next slide. Okay, so my diagnosis, my impression was severe aqueous deficiency dry eye for both eyes, secondary to rheumatoid arthritis, contact lens wear, and of course, she's menopausal. Next slide. So first and foremost, what we have to do is to stop her contact lens wear. Okay, or it's not going to get better if she continues. So I put her on a contact lens holiday for 2 weeks, and I started cyclosporine twice a day immediately. Okay, and of course I put her on dequafosol 6 times a day, and started her on a preservative-free lubricant, hyaluronic acid, Hyabac, every hour, and I'd ask her to follow up after 2 weeks. Next slide. Okay, so after 2 weeks, okay, improvement is slow. So her OSDI was pretty much the same or slightly increased. Okay, her slit lamp was pretty much the same. She had diffuse punctate epithelial erosions with filaments superiorly. She still had area break for her breakup pattern. Okay, and so at this point, I applied punctal plugs to both her lower puncta. Okay, and I continued the Icurvis and the Hyabac, and then I decreased the dequafosol to 4 times a day, and I started her on PEG 400, and I asked her to follow up in another 2 weeks. Next slide. Okay, by this time, 1 month after I first saw her, her symptoms began to improve. Okay, and of course, she still had diffuse punctate epithelial erosions with filaments superiorly. Okay, she still had area break. I applied the punctal plugs, which I didn't do the last time, and then I continued all her medications. Okay, and I saw her again another 2 weeks. Next slide. Okay, in 2 weeks, okay, her OSDI still increased. Okay, but she had decreased diffuse epithelial erosions. Okay, and her breakup pattern began to change, which was formerly area break, now with some line break. Okay, and so I continued the Icurvis and the dequafosol, and I asked her to follow up in 1 month. Next slide. Okay, and so as you can see here, I applied the punctal plugs, and her staining, still there, okay, began to dissipate ever so slowly. So patience is the key in trying to manage aqueous deficient dry eyes. Okay, next slide. Okay, so at 5 months, her OSDI has finally improved again. Okay, I continued. She still had the scant punctate epithelial erosions inferiorly. Okay, she still had area break with line break. I continued her medications. At this point, 5 months after she first saw me, this was only the time I had agreed for her to resume contact lens wear, and even at that point, well controlled. You know, only for performances and not. You know, she has to wear spectacles more often. Okay, next slide. Okay, and as you can see, there's so much less staining. I can now see a tear lake, okay, at the bottom lid margin, which wasn't there before. Okay, next slide. Okay, so the patient continues to follow up, but no more episodes of eye redness and no more visual discomfort, which is what she came in the first place. Okay, so she still wears contact lenses, but in strict moderation. And of course, her rheumatoid arthritis is currently under control with medications. So this problem is not going to go away. And so the key here, the goal, is to basically control her symptomatology, and hopefully she can see better and is able to wear contact lenses whenever she needs to. Okay, we'll go to the next presentation. Next slide. Okay, so my second case is a 41-year-old female, an office worker, and her chief complaint was eye pain and redness on the right eye. Okay, she had undergone bone marrow transplantation for acute lymphocytic leukemia. That's not leukocytic. Okay, next slide. Okay, and again, as in many of these cases, she's been seen by other doctors. Her current meds at that time was CMC every 2 hours and Lacrimvis eye gel every 6 hours. Okay, so patient has had previous bouts of severe eye redness and inflammation of the right eye, which only lasted 1 week. This particular episode her main doctor, her cancer doctor, had diagnosed her to have graft versus host disease, an episode of that. Okay, next slide. Okay, when I took her OSDI, it was very, very severe. Okay, it's a very high score. So she was very symptomatic, one eye more than the other. Okay, next slide. Okay, her vision on the left eye was not bad. It was 20/15, but on the right eye, it was 20/50. Okay, everything else was unremarkable. Okay, next. Next slide. Okay, tear breakup time was 1 second for the right eye, around 7 seconds for the left eye. She had area break on the right eye and random break on the left eye. She had a 0 Schirmer's test on the right eye. She had about 3 on the left eye. She had diffuse punctate epithelial erosions on the right, but there was no staining on the left. So the left was doing certainly a whole lot better than the right eye. Okay, next slide. So the breakup pattern for the right eye was area break with a breakup time of 1 second. Next slide. And for the left eye, random break with a breakup time of about 7 seconds. Okay, and you can see the lacrimal lake at the lower lid margin was a little bit much better, more discernible. Next slide. Now, this is the fornix on the right eye, and as you can see, she has symblepharon and a shallow fornix on the right eye, and this is attributed to her presumed graft versus host disease episode because of having undergone a bone marrow transplant. Okay, next slide. Okay, so her diagnosis was aqueous deficiency dry eye, right, more than left, probably secondary to GHBD. Next slide. Okay, so for her, I started her again on cyclosporine twice a day, diclofosol 6 times a day, cathianorm 4 times a day, and I asked her to follow up after 2 months. Next slide. Her OSDI improved markedly from 82 to 50, okay, and her vision too improved on the right eye, so from 20/50 to 20/30. Okay, on slit lamp, she had decreased punctate epithelial erosions inferiorly. T-FOD still showed area break, okay, but the left didn't show any breakup pattern at all, so it was almost like nearly normal. Okay, so I continued her Aqueous, her diclofosol, her cathianorm, okay, and then I asked her to follow up again after another 2 months. Next slide. Okay, and so this is the right eye, much less staining. I am a little bit skeptical if that'll actually ever go away. Maybe we within months or maybe a year of treatment, it might go away. But right now, that's still there. Left eye, next slide. Okay, so 4 months follow-up. Her vision was 20/33 and 20/15 on the left eye. Okay, still had punctate epithelial erosions inferiorly. Still area break on the right eye. No breakup pattern on the left. Okay, at this point, I applied punctal plugs bilaterally on the inferior punctum. Okay, and I continued her medications, and I asked her to follow up in 4 months. Okay, next slide. Okay, so her score remains to be much better than her initial score. It's still moderate to high. Okay, but her vision is much improved. Okay, to 20/25 on the right eye, still with punctate epithelial erosions, but scant erosions or staining on the left eye. Still area break on the right eye with no breakup pattern on the left. And I still continue her on all her medications. Okay, next slide. Okay, so this is the right eye. Okay, still but some staining. Next slide. Okay, so the patient is currently in remission from her ALL. She's obviously much less symptomatic. Okay, and we will most likely need dry eye management for life. Okay, particularly for her right eye. Okay, next slide. So what are the key messages? Well, inflammation in aqueous dry eye has to be managed aggressively and for the long term because there is usually a secondary cause. Okay, it's not the same parameters or not the same goals as with regular age-related or menopausal dry eye. So you have to message this properly to your patients. Okay, and cyclosporine 0.1% is very efficacious and safe for this particular purpose because we're going to treat them for such a long time. This drug has been proven useful and safe in trying to manage your patients long term. And I think that's it. Thank you.
Thank you, Ivo and Keisha, for your cases. Now, before we open the floor for questions, I would like to get some thoughts from the rest of the presenters about the first two cases. Any comments from the group, the team? If there are none, I have a question for Keisha. Hi, Keisha.
Hi, ma'am. Good evening.
Evening. Keisha, from your case, what do you think is the unique advantage of cyclosporine for post-refractive and or post-cataract dry eye disease patients?
Okay, thank you, ma'am. So, we all know that dry eye is really evident after cataract surgery and refractive surgery, and it's very important for us to identify those with pre-existing dry eye and to manage this effectively. Now, after cataract surgery or refractive surgery for that matter, there's actually a damage in your corneal innervation, and this corneal innervation handles a lot of functions in our tear film homeostasis, and one of that, aside from controlling the levels of inflammation, is also the decrease in particular components such as goblet cells. So it has been found that in LASIK surgery, for example, goblet cell density decreases, and cyclosporine can actually increase this. So that's one, I think, unique advantage of iCurvis or cyclosporine, aside from managing the inflammation.
All right. Thank you, Keisha. Are there questions from the group or from the audience? Okay. Here's a question for the group. This is in connection also to the lecture of Professor Leonardi earlier. No, in children with VKC, where the patient is a steroid responder, can cyclosporin 1%, 0.1%, be used as a first-line anti-inflammatory treatment after anti-allergy treatment has been administered? Anyone can answer from the group?
I can answer that.
Yeah.
Okay.
Go, Ivo.
So the question is appropriate because uh, iCurvis, no, cyclosporin 0.1% is indicated for VKC. Okay, and there are studies, in fact, towards this purpose. So it's not a drug that you can give after you give anti-allergy. It's actually
That's right.
a primary drug that you can now give for VKC. So, and uh, and as you can see, the case presented by Professor Leonardi, there was a patient on steroid who then forgot. It's always our fear in this country. Well, we start them with steroids and then it works and then they fail to follow up and then they get all sorts of complications. So for VKC patients, okay, cyclosporine 0.1% is highly indicated. The dosage is different. It's 4 times a day.
You have anything to add, Dr. Caparas?
No. Excellent. Excellent.
All right, right. Now, we have another question. Now, aside from corneal fluorescein staining and OSDI, does tear osmolarity have a role in monitoring for improvement after cyclosporin 0.1% treatment?
Oh, I can answer that one. Lately, I've not been very happy with the osmolarity results in the diagnosing or even tracking the progress of dry eye treatment. No? So, my short answer there would be no. I would not use it.
How about the others? Lisa?
It's not practical. There was the promise of osmolarity, not just for diagnosis, but for tracking all kinds of management for dry eye. But because of the prohibitive cost and sort of questionable accuracy in the first place, okay, then it has fallen favor in recent years. for this particular purpose.
Do you think that using imaging, just like keratograph, would be more helpful, or it would be more beneficial for patients in monitoring improvement after cyclosporine treatment?
Uh,
Yeah, sorry. Go ahead.
no, go ahead, Vic. Go ahead.
Definitely, you follow the tear stability and you follow the staining patterns. So that would be not only more useful but a lot more practical. Even GPs without these fancy instruments can follow. We're very lucky to have the keratograph, but you don't really need that. All you need is fluorescein dye and a slit lamp and a blue filter, and you can easily follow these patients. Yeah.
Okay, so if there are no more questions, we can proceed to the next presenter, Lisa.
Okay. I'll just share screen. Okay, so good evening. I'll be giving a short case presentation on the use of cyclosporine in a patient with Stevens-Johnson syndrome. So this is MC, a 24-year-old male college student with a chief complaint of blurring of vision on both eyes. He has been a patient of mine since maybe 12, 13 years. He was initially diagnosed with Stevens-Johnson's disease in 1999 when he was just 2 years old after intake of cotrimoxazole. So over the years from around 2007, when I first saw him, until around 2016, he had a relatively stable course. I maintained him on lubricants and occasional short course of topical steroids for flare-ups. In 2017, he went home to the province and was maintained on long-term topical prednisolone by a local IMD. So he came back to Manila in 2018, around May, and I noted that he had very high uncontrolled IOP on the right eye, which eventually needed valve surgery. So moving forward, about 1 year prior to consult, this was around September of last year when he started online schooling, he complained of frequent eye redness, eye pain, glare, and blurring of vision on the left eye. I restarted him on topical prednisolone and thromboamcin dexamethasone ointment at night. Couple of months later, he noted sudden increase in blurring vision and tearing on the left eye. So when he came to see me, he had a flat chamber secondary to a small central perforation, which eventually resolved with just BCL. And I had no choice but to continue topical steroids because there was a bit more inflammation at the time. So 1 month after that, I started noticing that the IOP on the left eye was slowly increasing. So I started him on Brimondine timolol drops twice a day, and this made the decision to also start him on cyclosporine 0.1% 4 times a day. In the meantime, I was also slowly tapering the steroids. So currently, I just saw him about 3 days ago. The left eye is comfortable, and the patient is now off prednisolone and anti-glaucoma medications. This is just a list of the surgeries that he's had over the years. Mainly entropion surgery on both eyes, electroepilation of trichiasis on both lower lids. As I mentioned earlier, the barbell valve implantation on the right eye for steroid-induced glaucoma. And he also had a perforation over the tip of the valve and which necessitated glue application. So currently, this is his eye exam results. Uncorrected visual acuity on the right is hand movement with fair light projection, is 2200 on the left eye. It was very difficult for me to refract him. IOP on the right eye has always been in the mid-20s, but currently the IOP on the left is just 7. So on gross examination, he has keratinized lid margins, superior tarsal conjunctival scarring, a fusing blepharon inferiorly, and trichiasis. So this is just a photo slit lamp of the right eye. No, as you can see, there is on the 11 o'clock position, there is the perforation with still surprisingly remnants of glue and surrounding vascularization. The right eye has always been better in terms of the cornea, and this is just the fluorescein staining picture. I apologize for the poor quality of the picture. And this is the left eye. As you can see, there is a central scar on the eye with a lot more vascularization and lipid deposition. This is really has main problem all along. And then the fluorescein dye. So when you look at the tear breakup pattern or the dry eye examination, the right eye has area breaks, BUT is about 1 to 2 seconds, and Schirmer test is maybe about 2 millimeters. The left eye is really much drier. There is area break, and the breakup time is practically negligible, 0. And the Schirmer test, actually, it really didn't become wet. So diagnosis for this patient is Stevens-Johnson syndrome with severe dry eyes. Current treatment of the patient is cyclosporine 4 times a day, brimondine 3 times a day on the right eye, lubricants, preservative-free lubricants as often as he needs them, and erythromycin ointment at night because the gel type of lubricant is just not sufficient. I have also instructed him with regards to lifestyle modifications. He's advised to wear goggles or glasses during online class, advised to set a timer so that it reminds him to take frequent rests or breaks. And then I told him to ensure the computer monitor is lower than eye level and to avoid any wind draft from electric fan or aircon while studying. So my key message is cyclosporine may be considered as a steroid-sparing alternative for patients with Stevens-Johnson syndrome, especially in the setting of steroid-induced glaucoma. So thank you.
Good evening. I will be presenting a case on the off-label use of cyclosporine 0.1% for herpes zoster keratitis. So this is the case of AP, a 44-year-old male management consultant who came in for second opinion for eye redness on the left eye. So the patient noticed vesicular lesions on the left side of his face in March of 2017, particularly in the forehead and nose, as you can see in the photo. He didn't seek consult right away, and after 1 week, he went to a dermatologist who just gave him skin ointment because the lesions were crusting over and no antivirals were given. So he decided to seek another consult with a dermatologist who told him to consult an ophthalmologist because he developed eye redness. So he went to an ophthalmologist in April of 2017 and was given ganciclovir 5 times for 2 weeks. He then was referred to a cornea specialist and was given prednisolone acetate 4 times and valacyclovir 1 gram once a day for a month. After 2 weeks, there was note of increased IOP, so pred was shifted to loteprednol and brimonidine was added. After 2 weeks, there was resolution of keratitis and the steroid was shifted to dapafenac. However, after 2 weeks, there was recurrence of the keratitis, so the loteprednol was again given with another course of valacyclovir. Even with the brimonidine, there was still an increase in the IOP, so this was shifted to bimatoprost plus timolol. And the patient decided to seek a second consult. So patient only wears spectacles and does not use contact lenses. The patient does not recall having had chickenpox in childhood. He has no post-herpetic neuralgia and only has allergic rhinitis for which he uses bilastine and antihistamine as needed. He is also not immunocompromised. So on objective evaluation, he is a myope with best corrected vision of 20/20 on the right, 20/20 minus 1 on the left. Corneal sensation is 100% on the right, 70% on the left. He has 0.4 cupping of slope discs with IOP of 12 and 16. His tear breakup time, the time was 8 seconds on the right and 4 seconds on the left. So the right eye was essentially normal. For the left eye, I saw multiple nummular anterior stromal infiltrates at the mid periphery, particularly at the 9 o'clock and 1 o'clock position, measuring about all in all 2 millimeters on the 9 o'clock and 1 millimeter on the 2 o'clock position. There was also superficial punctate keratopathy, but no pseudodendrites. He also had episcleritis nasally. Unfortunately, I wasn't able to take a photo, but I saw a similar case in one of the articles on stromal keratitis after varicella in children. As you can see, there are stromal infiltrates in the pupillary area. This is similar to what my patient had. So initially, I again started him on loteprednol 4 times a day, artificial tears, and gel at bedtime. Shifted the anti-glaucoma medication to dorzolamide plus timolol twice a day, and then tapered the loteprednol slowly when I saw resolution after 3 weeks. I also added cyclosporine 0.05% 3 times a day. So by after a month, I was able to discontinue the anti-glaucoma medication. So by October, he was on loteprednol once a day, every 3 days, together with the cyclosporine 0.05% 3 times a day. However, in November of 2017, he had a recurrence. So loteprednol was again increased to 4 times a day, and I added acyclovir 400 milligrams twice a day. After a month, loteprednol was again tapered. So there was again another recurrence in April of 2018. So loteprednol was again increased to 4 times a day and slowly tapered after a month. Acyclovir was discontinued after 6 months. So I was able to follow up the patient every 1 to 2 months, and he was doing well. In February of 2019, he was on loteprednol once a day, and I started cyclosporine 0.1% 3 times a day. So after a month, again, I was able to discontinue the loteprednol and decrease the Herpes to twice a day. He was still on artificial gel preparation 3 times a day. So he followed up every 2 months and was doing well. He had another recurrence in January of 2020, for which I gave loteprednol 3 times a day. And since discontinuing the anti-glaucoma medication, there hasn't been an episode of increased IOP. So loteprednol was again tapered after 2 weeks. Herpes was back at twice a day. So he actually, by this time, he already knows how to taper his loteprednol. So he was at once, this was when we were on lockdown. So he was on loteprednol once a day, every other day when I saw him in August 2020, and Herpes twice a day. So in December of that year, I noted a very mild recurrence of the stromal infiltrates, but decided to just wait and see. But in January 2021, exactly 1 year after, he again had a recurrence. So loteprednol was again given 3 times and then slowly tapered together with Herpes twice a day. So the last time I saw him was in August, and now he's totally off steroids, and estrus on Ecurvis twice a day, artificial tears 4 times a day, and a gel at bedtime. Hopefully, the vicious cycle has been broken. So the diagnosis is herpes zoster keratitis on the left eye. And usually the treatment for herpes zoster ophthalmicus is an oral antiviral like valacyclovir or acyclovir for a week, topical antivirals for epithelia keratitis, topical steroids for stromal keratitis or uveitis. This is to prevent scarring, neovascularization, and corneal melt, and also artificial tears for the accompanying dry eye. So we know that HZO peaks in healthy individuals in the fifth to seventh decades, but now we see younger patients having HZO. So in the US, over 99% of persons age 40 and older have had chickenpox, even if they deny any history. So reactivation of the varicella zoster virus is the main cause, and this is due to decreased cell-mediated immunity. So herpes zoster stromal keratitis can occur 2 to 4 weeks after HZO. Again, the pathogenesis of varicella-induced keratitis is still unclear, but an immune mechanism is postulated. Usually, they have a chronic course, like in my patient, and steroid dependence and relapses during tapering are the two main problems of management. So, as we know, steroids can induce glaucoma and cataract formation. So, cyclosporine 0.1% can be used to decrease dependence on the steroids and is safe for long-term use. Thank you.
Hi, we're back. For the last case, before I start the last case, I'd like to congratulate all the previous presenters for their excellent cases, and I hope mine is just as interesting. Okay, so the title of my case is an off-label use of cyclosporine A 0.1% to deter corneal graft rejection. The rationale for the use of cyclosporine for graft rejection is that immune rejection remains the leading cause of corneal graft failure, and it accounts for more than half of the cases of graft decompensation. The reported incidence of corneal graft rejection, depending on the study that you read, will vary from 2 to 68%. Now, overall, 30% of transplanted corneas will experience at least one episode of graft rejection or immune reaction, and 1/3 of that 30% will lead to eventual graft failure. An avascular, non-inflamed, or low-risk corneal host can expect a 5-year survival rate of 90% with just topical immunosuppression like steroids. Survival rate, however, dramatically decreases to below 35% in inflamed vascularized host beds or high-risk corneas. The rationale for the use of cyclosporine is as follows. The rejection of a cornea that has been transplanted undergoes 2 phases. The first phase is the induction phase. That means the host is sensitized to donor antigens, and corneal dendritic cells or antigen-presenting cells are activated. These APCs sensitize and induce the proliferation of T cells in the lymph nodes. The second phase is the efferent phase. This is mediated by the delivery of immune effectors to the graft site by blood vessels, now responsible for ultimately attacking the graft through a T cell dependent effector mechanism. Both CD8 plus and CD4 plus T cells which release inflammatory cytokines like interleukin 2, interferon gamma, interleukin 4, and interleukin 10 are the cytokines involved. Now, cyclosporine A inhibits interleukin 2. It leads also to a decrease in synthesis and secretion of several of the pro-inflammatory cytokines released in the efferent phase, such as interleukin 2, interleukin 4, interferon gamma, and tumor necrosis factor A. And it results also, and very importantly, in the inhibition of helper and cytotoxic T cell differentiation. So, with that as a background, this is the case. This is ADO, he's 49, a male, and a Roman Catholic priest. His chief complaint is on the right eye, and his complaint is of a loss of vision, sudden, very quick loss of vision with pain and redness. 3 to 4 weeks before he came, he had some eye discomfort and mild blurring of vision of the right eye, so that his reading was just slightly affected. However, 3 days before he consulted, he experienced a rapid progressive blurring of vision accompanied by severe eye pain, redness, and discharge. He gave no history of trauma, and he consulted his doctor, who gave him moxifloxacin and tobramycin every hour. Because his symptoms persisted, he was referred. He gave a history when he came to us 7 to 10 years ago that he had lost all vision in his left eye. And we had to just guess that it was probably due to a chronic uveitis. 7 years ago, he was diagnosed with primary open-angle glaucoma of the right eye, the affected eye in question, and he was started on travoprost, which was replaced by timolol and dorzolamide. 5 years ago, he underwent phacoemulsification with a multifocal IOL implant and achieved excellent results afterwards. He then proceeded to experience recurrent episodes of redness, for which he was treated by prednisolone 1% 4 times a day. But due to the pandemic and his inability to come to his doctor, he started self-medicating for several days to weeks at a time with prednisolone. So when he came to us, this is how he looked. As you can see, there's a very hazy cornea with an epithelial defect, inferior paracentral with feathery borders. There was a very deep stromal thinning, though the AC was formed but shallow. We also saw a hypopyon with fibrin material, which also started to coat the lens. His conjunctiva was very hyperemic, again with mucopurulent discharge, which even matted the lenses. And at this point, his vision was only hand movement with good light projection. So our impression was fungal keratitis of the right eye. There was a descemetocele, which was with an impending rupture. So while we were waiting for a tectonic corneal graft, we started him on natamycin every 30 minutes. And fortunately, we were able to get a graft immediately. So the following day, we proceeded to perform penetrating keratoplasty. And during the surgery, we introduced voriconazole intracamerally and at several points on the recipient bed. The photo on the upper left is the first day following the tectonic graft. As you can see, the graft is barely translucent, and you can still see these fluffy white infiltrates or maybe hypopyon within the chamber. After 2 weeks, we noticed that there were some infiltrates that already had started growing from the nasal area, as you can see from the lower picture. which necessitated repeated intrastromal injections of voriconazole. This fortunately recovered. So by about a month after the tectonic graft, that's how the cornea looks, and it's quite scary. It's very, very vascular with both deep and superficial neovascularization. And definitely, this patient has very poor vision. So again, that's the vision at about a month following. And once, because we had promised him, this being his only eye, he was really looking forward to being able to see again. And the only way he could see again is if we could replace the tectonic graft with an optical graft. So as soon as we were able to control the infection, the eye was very quiet. We started planning for an optical graft, which we gave a time limit of about 6 months afterwards. But we had to deal with the vascularization first. So we did a combination of fine needle diathermy of the feeder vessels and subconjunctival Avastin injections, and we did this 2 or 3 times. It was at this point as well that we started cyclosporine 0.1% 4 times a day. And after about 5 to 6 months, this is how his cornea looked. So you can say that we were able to significantly reduce the deep stromal neovascularization. Much of the neovascularization that you see is quite superficial due to some conjunctival overgrowth. So we were able to perform a nice optical graft. This is day 35 following the optical graft. And his vision was 20/50 despite everything. And I guess he had special help from above, him being a Catholic, a priest. So that's what we always joke him. And we've been able to keep his graft nice and healthy. The picture on the right is from day 87, almost 3 months after the procedure. His vision here is with pinhole, it's 20/30, and uncorrected, it's 20/40. So he's very, very happy. And he's a very, very good patient with a great attitude. And when you ask him to come, he will come, and he follows everything. So it helped a lot. Okay, so this is just a collage. It's like a time-lapse photography of his story from day 1 when we did his tectonic graft all the way to day 87, where you can see how clear his cornea is. No? And for this, I have to thank our cornea fellow, Tina Tan, for putting this together. So I saw him yesterday. That's how his cornea looks. His vision is 20/40 uncorrected. We took a K5 test. His tear meniscus height is low, but 0.16, that's not so bad. His non-invasive BOT, breakup time, is a little low, 5.5, but again, not that bad. We took osmolarity just for the heck of it, and it was hypoosmolar. And his OSDI was 35, so it's about moderate eye disease. Although this patient has such a good attitude, he never really complains, and you'd think that he is so comfortable and he's just so grateful that he can see again. On the upper right, you can see the state of his meibomian glands, and you can see that he has some serious moderate MGD as well. No? And the bottom right just gives you a nice summary of his findings. So as you can see, he has some punctate keratopathy. But you can also see that after each blink, his BUT, his breakup time, is not so bad, and the dye is fairly stable in his eye. No? So it's not really bad at all. And you can see, and that would also explain why he can see pretty well. Remember, he has a multifocal, which is very, very sensitive to aberrations on the corneal surface. So it would seem that cyclosporine may have contributed to the success, but there are also some caveats. Okay, it's topical cyclosporine has been used fairly regularly since its introduction in about the middle 2000s, but its efficacy, it's still hard to pin down exactly if it works or how it works. There was a survey of the Cornea Society done back in 2004, and about half of the members used it regularly to prevent rejection in high risk grafts. Um, Others reported that using a concentration of 2% resulted in improvement of the rejection free rates. Michael Bellin himself described improvements of both rejection-free and survival rates using cyclosporine. However, if you look at other prospective studies done, they fail to show how topical cyclosporine helps in reducing the graft rejection rate in whatever concentration or whatever risk setting. So the key messages here is that I've been using cyclosporine for maybe 15 years as a deterrent to graft rejection, and my experience has been generally good. Um, the things that you might want to consider, though, it should be started well before the transplant, months before. And in this patient that I showed, we were using it for 6 months, slightly over 6 months before we actually did the optical graft. And of course, you should resume it immediately after transplant. And he's still currently on it right now, along with loteprednol. See, so one good thing about cyclosporine, as you have seen in all the presentations practically, is that it helps to reduce the amount and possibly the type of steroids that you're using, so that you can use a weaker type of steroid like loteprednol. It should never be used as a single therapy. It should always be used as an adjunct. And of course, you also have to look at reducing the vascularity of the surrounding areas as well as other issues. That plus the additional benefit to the ocular surface. So this patient not only has not had any graft rejection episode, he actually sees well because his ocular surface is good. So that's it. Thank you very much.
All right. Now that we've listened to the last three cases, we can now open the discussion once again. Now, do any of our presenters have questions about the cases that were presented? There are none. Do we have questions from the audience? I think there's one. Okay. Anyway, so for VKC again, can we use cyclosporine 0.1% as a daily prophylactic? I think this was answered by Professor Lenardi earlier. No, we can use it as a daily prophylactic maintenance treatment for those to prevent future exacerbations. Any thoughts from the group?
Well, I think you can just use it as long as it's needed. Uh, my experience with cyclosporine, some of my patients have used them for even longer than 12 months without any real side effects. So the answer probably there would be yes, you can do it.
Ivo?
It's
You're raising
important to remember. It's important to remember in VKC that if you manage it properly, patients will outgrow the condition. So when you say you can use it for long term, you can, but doesn't mean the rest of their lives, because they
Yeah.
will grow up and they will outgrow the condition and they will eventually not be putting cyclosporine anymore when they've outgrown the condition. The important thing is that while it's active, while they're prone to certain complications of VKC as children, then this is highly indicated for that, and you can use it for the long term.
Okay. Other comments?
Well, I have a follow up. The question about GPC, which the Professor Leonardi didn't really answer, and because it may be different in Italy where um, most people are just using soft daily disposable lenses. But here in the Philippines, a lot of people can't afford to keep changing contact lenses. So GPC is quite common here, correct? And I'm suppose all of you will agree with me. And especially some of the patients we have. I deal with a lot of keratoconus patients, and many of them are on RGPs, which they cannot remove. They cannot stop because they can't see well with just glasses. They have to use the RGPs. And so I have found that 2, 3 years into the RGP, inevitably they develop a GPC. Okay, so uh, aside from putting them on pulse steroid for a couple of weeks, I start them on cyclosporine already, and I have had very good success keeping them on the RGP. And it's necessary because they really need to wear the contact lens to see.
The only question about drops and contact lenses is that can they put it while wearing the lenses?
Yeah.
Okay. And because it's not been tested in this way, okay, you may put it, but it's a good thing it's only once a day or at the most twice a day. They should put it after they've put their contact lenses away for the day and or before they put it on in the morning. But that has to be emphasized for these patients because putting these drops with the contact lens on has not been tested, so we don't know its absorption. We don't know whether it's going to react with the lens, and so I think you can use it. That point just has to be emphasized when we do use it for contact lens.
Yeah. Yeah. I do remind them to take their lenses off and to wait about 30 minutes before reapplying the lenses.
Um, Other questions? All right, I think this is for Lisa. Can cyclosporine be an option for SJS patients with a sequelae of dry eye, not fully relieved by preservative-free lubricants?
I think it's a possibility. Although I would probably start off with any steroid drops like prednisolone or loteprednol initially, just because, as we know, cyclosporine takes several weeks to take effect. But at least just overlap it a little and then eventually wean off the steroid so that you don't really run into the steroid related complications such as cataracts and glaucoma. But it might be a viable option really for these patients.
All right. I think we have one last question before we end this episode. Okay, what is the mechanism? What is the mechanism and why does vernal keratoconjunctivitis resolve as the child gets older?
Mechanism.
That one.
So like many allergic diseases, okay. So it's been identified that VKC is a disease of childhood, okay, and its presentation, like many allergies, dissipates as we get older. Sometimes like childhood asthma, okay, except that this is better defined. So VKC as a ocular entity, okay, is something that is found in children. It has a very clinical presentation uniquely found, okay, but it's within the spectrum of ocular allergy, and its clinical presentation is that it does dissipate as you get older, not to a predictable level all in the same age. For example, they can dissipate by teens, some even later, well into their early 30s. But the general rule is that it will dissipate as you get older. Okay, and so key to this is that you need to follow up your patients to see how many recurrences or how many attacks they're still getting as they get older. How does it happen? Well, just like many allergic issues like rhinitis, asthma, skin diseases, these come and go in the course of one's lifetime. But for VKC, it's something that's peculiar in childhood, which you outgrow.
I think that's about it. Thank you, Ivo. Thank you to everyone. Dr. Caparas?
Yeah, I want to thank everybody and the audience. This is the last episode of ITV for the year 2021, and I hope that we'll see you again next year. We'll probably be back with even better episodes. Thank you as well to Santen for your never flagging support for us. Thank you.
Okay, so we hope to see you again in the next episode of TMC ITV in 2022. So good evening, everyone.
All right.
Bye-bye.
Bye.